Hi, everybody. We're here today talking COPD, level up your COPD management. My name is Sonali Bose. I'm an associate professor in the Division of Pulmonary Critical Care and Sleep Medicine at Mount Sinai Hospital. Also have an adjunct position at Johns Hopkins. And I'm here today with my colleague, Dr. Meilan Han from University of Michigan. We're going to be talking today about the new data and management guidelines that were recently incorporated into Goal 2025. And upon the completion of this activity, you should be able to do the following. Number one, evaluate recent evidence and guideline updates presented at 2025 conferences to enhance your clinical decision-making for COPD, to apply some of the evidence-based strategies that we'll be discussing for personalized treatment, to analyze case scenarios to identify optimal ways of managing COPD in real life, and to integrate new clinical insights and some new solutions that we can then more holistically improve our care of COPD patients. So to start off, I wanted to review the definition for COPD. Of course, the definition for COPD has evolved, and our understanding of the risk factors for the disease has evolved significantly over the last 10 to 20 years. Some of the new concepts in Goal 2025 include an idea that COPD does not begin overnight and that there are states prior to the development of frank disease that are reflective of the patient's abnormalities in both physiology and structure. Some of the new concepts or terms that you might encounter include pre-COPD, where individuals may have symptoms or functional or structural abnormalities, but don't quite meet the criteria for an FEV1 over FVC of less than 0.7. In addition, conditions such as PRISM may highlight the fact that you may not necessarily reach the ratio below that cutoff. However, you might find that other aspects of spirometry values might be at deficit. And these individuals are important to recognize because they may be at risk for progressing to COPD down the road. The management of COPD has also evolved significantly over especially the last few years, where we are starting to have an increased armamentarium towards managing our patients' diseases. So first, of course, we always discuss how we must get to the right diagnosis and incorporate information about symptoms and risk factors, as well as the physiologic data from spirometry. Our initial assessment of the patient has to be quite holistic and include not only just lung function and symptoms, but also some of the other comorbid conditions that they have, their early life risk factors and their exacerbation histories, and newly, an idea that the serologic data is also important, in particular blood eosinophil counts. Our initial management hasn't changed all that much in the sense that we still incorporate things like smoking cessation and behavioral strategies. However, the pharmacotherapy range has greatly widened. And so today we'll be talking about how to tailor the pharmacotherapy as well as some other non-pharmacologic therapies, particularly to patients depending on all of these domains. It's really important to remember that you have to review all this data and incorporate it eventually into your management. So what are our goals? Our goals are fairly straightforward. We, of course, want to reduce the symptoms. This is a patient-oriented type of goal because the patient also wants to relieve their symptoms. They want to be able to improve their exercise tolerance as well as their health quality of life. So that should be a shared goal as well. We want to make sure that we reduce their risk, for example, risk of exacerbations or progression of disease, and ultimately mortality. We certainly want to improve their functional status so that they can do the things that they want to do and stay independent in their daily activities. And finally, to optimize their therapy and their engagement in that therapy, as we understand that it really takes two to manage this going forward. Not only do we try to meet the patient to get the best therapy that fits for them, but also that they must stay engaged and participate in these programs. We'll be talking a lot today about pharmacologic management because this is really an area that has seen a great deal of advancement in the last 10 years. The new gold recommendations are building upon the prior ones where we discuss COPD groups as belonging to A, B, or E. And here you can see some of the criteria that define each of these groups and accordingly the types of therapies that we assign to patients this way. And you can see that for patients, we first decide if they are having exacerbations or if they're having not really that many exacerbations. And so you can see 0 to 1 moderate exacerbations, not really the patient that's going to the hospital who really belongs in this group A or B category. The deciding factor between those two groups really comes down to their symptom burden. And here we can see that some questionnaires that we've incorporated into our clinical practice, which include MMRC and CAT, really define membership in one of these groups. So if you're not an exacerbator and you don't have that many symptoms, you are in the group A category. But if you have minimal exacerbations and quite a bit of burden of symptoms, for example, dyspnea, you would belong in the group B. You can see here that our choice of drugs can include either a short or long-acting bronchodilator versus a LABA-LAMA combination. On the other hand, you have patients who have frequent exacerbations and are coming to the hospital or medical care frequently. They'll be belonging to the group E patients. And there you want to think about additional therapies, mainly the addition of an inhaled corticosteroid. The decision there, which we'll elaborate further down the road in this presentation, also depends on their symptom burden and morbidity. We'd like to say that we prefer patients to be in a LABA-LAMA combination when possible and not so much the bronchodilator alone group. This has been shown to be preferred and more helpful with dyspnea symptoms. And I want to emphasize that the care coordination in COPD really involves numerous stakeholders and numerous people who are involved in the day-to-day functioning of this patient. Patients are now becoming a part of a whole entire health system, which allows them to interface with numerous types of allied healthcare professionals, including nurses, PAs, their primary doctor, potentially some home help, as well as specialties that are apart from pulmonary critical care. With the improvement in our referral basis to pulmonary rehab, they are also frequently interacting with PR specialists as well as other therapists. And so it's really important to remember this web of healthcare providers that the patient is continuously working with and really to optimize their care through these portals. So I'd like to pass it along now to my colleague, Dr. Han, who's going to be talking a little bit about the recent evidence and data that we've been hearing through conferences as well as published data.